Okay, good evening, everybody. It's my duty to give you a talk in relation to metformin extended release, glucophage XR. This lecture is sponsored by Merck. And as we know, pre-diabetes and diabetes worldwide are extremely common. Here in Dubai, the prevalence of type 2 diabetes is somewhere between the range of 15 to 20%. With respect to pre-diabetes in adults, we're talking somewhere between 15 and 25%. And quite worryingly, in the youth who are overweight or obese, the range is also about 5 to 20%. We know that most of the people we see with pre-diabetes and type 2 have got associated obesity, and we generally use the term diabesity. We know that pre-diabetes and type 2 diabetes are both major risk factors for cardiovascular disease and also microvascular complications. And we also know that we need individualized, patient-centered strategies to really address the public health pandemic, really, of pre-diabetes and type 2 diabetes. Now, the guidelines from the American Diabetes Association have clearly focused, like all professional groups, on patient-centered care, shared decision-making, individualized treatment strategies and goals, and the use of lifestyle measures, including medical nutrition therapy and exercise, right from the get-go. In addition, they also recommend that metformin should be the first-line therapy that in the majority of our patients should be used really from diagnosis. The reason why metformin was chosen to be used right from the initial diagnosis is based on the clinical effectiveness, the real-world effectiveness of this agent, the great safety tolerability profile, and extensive clinical experience. These metformin drug has been used since the 1950s in Europe and since the early 1990s in the US. What do we know about metformin? It's an insulin sensitizer in as much as it decreases hepatic glucose production, reducing gluconeogenesis, and decreasing that fasting glucose. And it also works peripherally to improve insulin-mediated glucose uptake in predominantly skeletal muscle, but also adipocytes. We also know more recently that it has an incretin effect, increasing GLP-1 levels to about the same degree that DPP-4 inhibitors actually increase GLP-1 levels. With respect to both efficacy, which is what you see in clinical studies, and effectiveness, which is what you see in the real world, it's ideal really to try and use the maximum tolerated dose, usually up to about 2,000 milligrams per day. If that is achieved, then you can anticipate having very robust reductions in both fasting glucose and also HbA1c of the order of 1 to 2%. There's some other beneficial effects. One, you don't really get any weight gain, and you can actually get modest weight loss. And in one of the big diabetes, pre-diabetes studies, over 15 years, there was about 2.5 to 4 kilogram weight loss. So that's very encouraging. You also don't get hypoglycemia, and there's many other putative benefits, including cardiovascular disease reduction, which was seen in the UK-PDS study. And the results showed both a reduction in myocardial infarction, any diabetes-related endpoint, including death, and all-cause mortality. And this was seen in the specific cohorts that were overweight. And that was defined as a BMI of 25, or in those days way back when it was 120%. With respect to that study, the UK PDS, this is just drilling down a little bit more on the initial intervention results after 20 years, and also the kind of observational study, which was a further 10 years. And you can see that the metformin group in those overweight population really had tremendous effects, which were very durable. And all of the results in the observational study were highly statistically significant. And we have this kind of dose effect study from the late and great Alan Garber, which showed that the higher the dose, the better the glycemic reduction. And if we can try and achieve that dose of 2,000 milligrams a day, then we can expect that 2% A1C reduction. And this is just a study which was observational in just over 3,000 patients who had newly diagnosed type 2 diabetes. And when you look at the overall cohort, you can see that 7 out of 10 of them got an A1C below 7%. And if you look even in that group which had a very high baseline A1C, greater than 9, 60% actually got below 7%, in addition to lifestyle treatment. And if we look at other oral agents, which are the usual methodology of initiating treatment in type 2 diabetes, you can see that both metformin and sulfonylureas have got by far the best glucose lowering capacity. The advantage for metformin over SUs is that it's much more durable, as I've just shown you the results over many years with respect to weight loss, and also some of those complications is really excellent. If you look at TZDs, which are not widely used these days, you can anticipate up to about 1.4% A1C reduction. SGLT2s, it really depends on the baseline kidney function, and DPP-4 inhibitors, as we know, you're really going to get probably about a 0.5% A1C reduction. What about the adverse effects of metformin? So we know that we have to be somewhat careful in people with chronic kidney disease, and this is a very common association of diabetes. And when we get to the stage of an eGFR less than 45, then we really need to be careful if we're going to initiate it. And we also need to be careful with the dose. So we have to decrease the dose, usually to about 500 milligrams or something like that. Once the eGFR gets below 30, then strictly speaking, it's contraindicated. The major concern historically has always been the risk of lactic acidosis, and this is very rare. And if the metformin is properly prescribed and there's really no other complicating factors like acute kidney injury or cardiorespiratory failure, then this really shouldn't happen. With respect to B12 deficiency, this occurs possibly in about 7% or thereabouts. And it's a good idea to check the levels every 2 or 3 years, but especially if the patient has got neuropathy or unexplained anemia. The major baggage associated with biguanide agents, of which metformin is one, is the gastrointestinal side effects. And this occurs in somewhere between 15 and 20% of patients. And when using the immediate release formulation, about 10% of patients can never tolerate it. One way that we can risk mitigate that is by starting low and going slow. So starting with 500 of the immediate release formulation with the main meal, and then after a week or so, depending on tolerability, increasing to 1,000, and then eventually 1,500, and then up to 2,000. Alternatively, we can use the metformin extended release formulation, Glucophage XR, which has got a much lower risk of GI side effects. In addition, if one of your patients is on the immediate release metformin formulation and has GI side effects, then you can switch to metformin XR. The reason why the extended release formulation has got such a good GI profile is that you get delayed absorption, but while still maintaining excellent systemic exposure to metformin. The way that it does that is by this gel shield technology, where the outer polymer swells due to hydration once it's in the gut, and the metformin must penetrate that outer gel to be released. And you can see the profile in blue of immediate release formulation, which is given twice a day usually. Sometimes it's given 3 times a day. But on this particular pharmacokinetic study, you can see that the XR formulation in red, you get a much higher Cmax, but the area under the curve is exactly the same as you would get with the twice daily immediate release formulation. And therefore you can anticipate getting the same efficacy and effectiveness with respect to reducing glucose measurements, whether it's fasting or A1C, but you also get less side effects. And you can see here on the left in red that you get a 50% decrease in GI side effects in metformin naive patients in the first year of therapy. And you can see particularly troublesome is diarrhea, and you get a 75% reduction when you use the extended release formulation in comparison with the immediate release formulation. Now, how do we use it? In metformin naive patients, again, you would go low and go slow, and you would build up gradually to about 1,500 milligrams a day or 2,000 milligrams a day. And that is for the pre-diabetes indication. With respect to diabetes, I've already mentioned that if you can get people to 2,000 milligrams a day, then that would give the maximum benefit. And if your patient is already on immediate release metformin, then you can actually easily convert to once daily administration of the extended release formulation. And there's various different combinations, which you can see there, which equates to the immediate release dose. And we give it with the main meal of the day. Let's just turn now to pre-diabetes. So I've really said that the gold standard treatment from the get-go is metformin if it's not contraindicated and it's tolerated. With respect to pre-diabetes, you can see that we know that our patients are overweight, obese, many of them, they have associated insulin resistance, and you get this so-called Starling law of the pancreas, whereby in order to compensate for the increased insulin resistance, you get increased beta cell secretion, but eventually over time that fails, and then that leads to perturbations in the glucose levels. And initially, you get a postprandial increase in glucose, and that is due to the loss of the first phase insulin secretion. And you can see initially it will go through the pre-diabetic threshold and eventually type 2 diabetes threshold. And then thereafter, you get increases in fasting glucose typically, again, going through the pre-diabetes category and then potentially converting to type 2 diabetes. And what we know about insulin resistance and associated overweight obesity, especially central adiposity, is that this is a key pathophysiological association of the metabolic syndrome. And the metabolic syndrome are really this aggregation of risk factors in a given individual, which can lead to increased cardiovascular disease, as well as type 2 diabetes. Not only do you have increased macrovascular risk in this association, but you get increased non-alcoholic fatty liver disease, and cancer also is much more prevalent, and maybe between 10 and 12 different cancers are strongly associated with overweight obesity and the metabolic syndrome and type 2 diabetes. The risk for microvascular disease really is all about glucose. So I guess what was surprising is that in the diabetes prevention program and many other studies subsequently, is that even in that pre-diabetic range, there was an increased risk of microvascular disease, which is very, very tightly associated with glucose increases. And what we can see in the box on the left-hand side is that if we want to reduce these complications, then we really need to kind of intervene early on in the natural history. And you can see that red line is the kind of time between the diagnosis of prediabetes by IFG category through to when it transforms into type 2 diabetes. And it can take 5-10 years, sometimes quicker and sometimes longer. So that gives you time to intervene with appropriate lifestyle, but also with metformin, as I will share with you. Now, just going back to that microvascular risk in prediabetes, in this study, you can see polyneuropathy occurs in about 7.4% of normal glucose tolerance individuals, and is higher in both IGT and IFG category. When you think about diabetic retinopathy, this is uniquely related to diabetes. It's not seen in any other disease state. And you see exactly the same sort of pattern. About 10% of people with prediabetes have got microvascular complications. 10 years ago now, I worked at the Joslin Diabetes Center, and I just said, look, in an ideal world, these high-risk people with both metabolic syndrome, prediabetes, should have an intervention to stop progression to full-blown diabetes and all those various complications that I mentioned. At that time, just 11 years ago, 57 million people in the US had prediabetes, and you can see just a year ago, that has increased to 90 million, or 1 in 3 adults. So this is a huge public health problem, as I mentioned. When we follow people with prediabetes, about 5 to 15% will annually convert to diabetes. Certain groups, especially those with previous gestational diabetes, those patients with both IGT and IFG, those with a positive family history of diabetes, and those who have a high pre-diabetic range A1C or fasting glucose, so maybe between 6.1 and 6.4% A1C and 110 to 125 IFG, have a much higher likelihood of converting. The DPP study was performed at the NIH in the US. I was working at the NIH in Phoenix at the time, and this study was compared to placebo, and it had 2 active groups. One was intensive lifestyle, which was really focusing on diet and weight loss, about 7%, and increasing exercise, 150 minutes a week, compared with metformin 850 BID. And you can see that the best reduction was with intensive lifestyle, but there was a statistically good decrease in the metformin group compared to the placebo arm. And this study has now been again followed in an observational way for 15 years. And the reductions are still there, but they're not quite so great. And the difference between the lifestyle group and metformin are not so wide. So that's kind of interesting. And it's interesting because when you drill down a bit, even in that initial study, you can see that some people with pre-diabetes, IGT category, actually had even better reductions in conversion rate. So those who were obese, those women with a history of gestational diabetes, those with the high fasting glucose, as I mentioned, and the younger all did much better with metformin compared to the group overall. And if you look at a meta-analysis across most of the studies which have been published with respect to the role of metformin in prediabetes, there's about a 40% reduction. So that's really pretty encouraging. And again, I wrote this paper with a colleague from the NIH, Rich Prattley, and we said even 10 years ago that metformin should be considered first because of its favorable overall profile. And now we know that glucophage XR is the only approved medication for the prevention of diabetes globally. And it's been really supported by many professional groups, such as the one in the NICE in the UK, as well as the Emirate Diabetes Society here in the UAE. And you can see that the way that they really approach it is that you diagnose prediabetes, you intervene with lifestyle. If after 6 months you really don't get any benefit, then metformin should be added to the treatment. And just to conclude, so metformin is the current gold standard treatment for both monotherapy and combination therapy of type 2 diabetes, and that's supported by all the professional groups really around the world. You really need to up-titrate the dose to get to the treatment target, which is between 1,500 and 2,000 milligrams per day. And with that dose, you're going to have a low risk of side effects, and you're going to get a durable glycemic effect. And metformin, even when you add additional treatment, should be continued if the patient is tolerating it and no contraindications of a kind of evolved, like the kidney function, for example, has got worse. Glucophage XR provides once daily dosing, so that translates into better patient adherence and persistence, and reduction in GI side effects. And really, this molecule is evolving, so the effect on cancer and all sorts of different putative benefits are really being explored as we speak. And glucophage XR is the only approved medication for the prevention of type 2 diabetes, exactly the same dose as diabetes. And this is why we kind of framed it as this diabetes continuum. We start it in the pre-diabetes phase and continue it through the natural history of diabetes. If the patient converts, then we can really improve adherence and tolerability because we're keeping it simple. And we can also get that legacy effect and metabolic memory. And I thank you, and I'll hand back to the conference chair. Thank you.